Hello, I'm Han Quach from St Vincent's Hospital, Melbourne, and the University of Melbourne. At this year's ASCO and EHA conferences, I had the privilege of presenting the initial result of part 1 of the MagnetisMM-6 study. This study investigates the combination of Elranatamab, a BCMA-targeted bispecific antibody with daratumumab and lenalidomide for the treatment of people with newly diagnosed transplant-ineligible multiple myeloma. The data is truly exciting, I think, because it represents a beginning of a shift towards frontline T-cell redirecting therapies, aiming for a deep and durable response that may allow some patients to achieve long-term disease control with just one line of therapy and ultimately reach their natural lifespan. There is a strong scientific rationale for this combination. Elranatamab binds to BCMA on myeloma cells and engages T cells to mediate direct immune-mediated myeloma cell killing. Daratumumab is a monoclonal antibody, and it works through what we call antibody-dependent myeloma cell killing via natural killer cells. And it also enhances T-cell function, as does lenalidomide. And together, this triplet combination activates both the innate and the adaptive immune system, delivering a synergistic immune-mediated attack on the myeloma cells. The data presented at ASCO and EHA focused on dose level G from part 1 of the MagnetisMM-6 study. This consists of elranatamab at 76 mg given subcutaneously every 4 weeks after step-up dosing, combined with the standard doses of subcutaneous daratumumab at 1,800 mg and oral lenalidomide 25 mg in a 28-day cycle. It's important to note that elranatamab is given every 4 weeks from the outset, unlike the weekly dosing used in the approved relapse refractory setting. And this less frequent dosing may help reduce treatment-related side effects while maintaining efficacy when used in combination. Amongst 37 patients with newly diagnosed multiple myeloma with a median age of 75, with approximately a quarter of patients classified as frail based on the IMWG frailty score, we observed a predictable and manageable safety profile. Adverse events were expected for each drug individually within this combination. Hematological toxicities occurred in approximately 83% of patients, but grade 3 and 4 neutropenia were seen in just under three quarters of patients, while grade 3 or 4 anemia, that is severe anemia and thrombocytopenia, were less common at 19% and 11% respectively. But overall, these complications were very easily manageable and there were no concerns. And as anticipated, cytokine release syndrome, or CRS, was quite common, seen in 62% of patients. But all of these cases were grade 1 or 2, that is, they are mild. And importantly, there was only one patient who experienced grade 2 ICANS. Infections occurred in about 70% of patients, with only 19% being grade 3 or 4. And the most frequent infections were upper respiratory tract infections and urinary tract infections. And just for perspective, this degree of severe infection is in fact lower than what we would expect with a bispecific T-cell engagers when used in the relapsed refractory setting. In terms of efficacy, we saw an impressive overall response rate of over 97%, with approximately 95% of patients achieving a very good partial response or better, and 27% achieving a complete response. Now, note that the rate of complete response here may be an underestimation, as many patients in very good partial response have yet to have a bone marrow biopsy to confirm complete response at the time of this presentation. Disease control was quite rapid, with a partial response or better occurring after a median of 1.5 months. And these responses deepened over time and were durable, with most patients responding and remaining on treatment, at least in a very good partial response at a median follow-up of 8 months. In short, the part 1 of the MagnetisMM-6 study have confirmed that a 4-weekly dosing schedule of Elranatamab combined with daratumumab and lenalidomide is highly deliverable and effective for the treatment of people with newly diagnosed multiple myeloma who are not eligible for stem cell transplant. This dose and schedule of the triplet combination will be brought forward as the recommended Phase 3 dose and will be explored further in the randomized Phase 3 portion of the MagnetisMM-6 study in the upcoming Part 2. Here, the combination of Elranatamab every 4 weeks with daratumumab and lenalidomide will be compared with daratumumab, lenalidomide, and dexamethasone in transplant-ineligible or transplant-deferred patients with newly diagnosed multiple myeloma. And so overall, I think the MagnetisMM-6 study is exciting because it marks the beginning of a new era of bringing powerful immune-based therapy to the front line. The ultimate aim here is to help people with multiple myeloma live longer, healthier lives, ideally reaching their natural lifespan. And if we can achieve that with just one line of therapy, I think it would be nothing short of transformative. I will end on that note and thank you for listening.